Hello, everyone, and welcome to March IBD Journal Fellows Corner Talk. My name is Anam Omer, and it's my absolute pleasure to present a very important study from the American Journal of Gastroenterology, published in July 2020, titled Post-Operative Endoscopic Recurrence on the Neoterminal Ileum, but not on the Anastomosis, is mainly driving long-term outcomes in Crohn's disease. Ileocolonoscopy within the first year after surgery is gold standard to evaluate recurrence after ileocolonic resection for Crohn's disease. Redgear score is used to assess the severity of endoscopic recurrence after surgery. Severe lesions, I3 or I4, are clearly associated with poor long-term outcomes. I2B lesions with ileal and anastomotic involvement is associated with higher global inflammatory burden. The aim of the study was to evaluate the association between the presence and severity of anastomotic and ileal lesions at early postoperative ileocolonoscopy and the long-term outcomes. This is a prospective multi-center study performed by the Remind Group. Patients with ileal or ileocolonic Crohn's disease who had undergone surgery were included from September 2010 to December 2016. Post-operative treatment with an anti-TNF agent or azathioprine was recommended to patients with risk factors. Ileocolonoscopy was performed 6 months post-surgery to assess the endoscopic recurrence and its severity according to the Redgear score. Risk factors included current smoking, previous bowel resection, penetrating phenotype, and active perineal disease. Patients with no risk factors were not given any treatment. Patients with one risk factor were placed on azathioprine. Patients with two or more risk factors were treated with anti-TNF as a monotherapy or in combination with azathioprine. Ileocolonoscopy was performed at 6 months. Lesions in all segments, including the anastomosis and neoterminal ileum, were reported. Redgear score was given by the endoscopist. Two physicians graded together each postoperative endoscopy, describing separately the anastomotic and ileal lesions. Two other physicians verified the score consistency. Long-term data of patients with follow-up of at least 18 months was collected retrospectively. The anastomotic lesions were given 4 grades: A0, no lesion; A1, ulceration covering less than 50% of the anastomotic circumference; A2, ulceration covering more than 50% of the anastomosis circumference; A3, anastomotic stenosis. Ileal lesions were given 5 grades: I0 as no lesion, I1 less than 5 aphthous ulcers, I2 more than 5 aphthous lesions with normal intervening mucosa, I3 diffuse aphthous ileitis, and I4 diffuse inflammation with larger ulcers. Long-term data was collected for at least 18 months and included clinical relapse, which was defined by Crohn's disease-related symptoms confirmed by imaging, endoscopy, or therapeutic intensification, Crohn's disease-related complications or need for subsequent surgery. Objective disease progression on colonoscopy or imaging was also reported. The initial cohort included 225 patients who underwent post-operative endoscopic evaluation. 32 patients were lost to follow-up, and the final cohort included 193 patients. Moving to results, the median follow-up after surgery was 3.82 years. Median recurrence-free survival was 47.6 months. 47% of the patients had recurrence, 4% at 1 year, 36% at 3 years, and 60% at 5 years. For ileal evaluation, clinical recurrence-free survival was significantly shorter in patients with ileal lesions on post-operative endoscopy, irrespective of the severity, I1 to I4, compared to patients without ileal lesions. By contrast, the anastomotic occlusive complications were not significantly different. Moving to anastomotic evaluation, interestingly, clinical recurrence-free survival was not significantly different in patients with or without anastomotic lesions, irrespective of the severity. However, patients with at least semi-circumferential anastomotic ulceration, A2 or A3, had more anastomotic occlusive complications than patients without anastomotic recurrence. Overall, patients with exclusive ileal lesions had poor clinical outcomes than patients with exclusive anastomotic lesions. This is overall a very strong study, but had one limitation, which was rightly pointed out in the paper as well, which was absence of central endoscopist evaluation, possibly leading to misclassification. However, they did overcome this by verifying all the scores prospectively through central database. Moving to discussion, ileocolonoscopy performed at 6 months after surgery continues to be the gold standard. Most post-operative Crohn's disease patients require Crohn's disease-specific medical treatment. Medical therapeutic intervention may reduce the severe complications leading to subsequent surgery. Tailoring treatment in a step-up fashion according to early postoperative colonoscopy reduces clinical recurrence. Then endoscopic cutoff to optimize medical therapy is a Rutger score of I2. Ileal lesions, whatever the severity, 6 months after surgery, are associated with poor outcomes and low recurrence-free survival. This study proposed a new score for postoperative endoscopic recurrence, describing separately the anastomotic and ileal lesions to better characterize patients with high risk of recurrence. Thank you.